Hello, my name is Tabbone Ferro, and this presentation is about acetabular labral tears. The objectives of this presentation are to appreciate the high prevalence of labral tears, improve our diagnostic accuracy for labral pathology, raise awareness about the reliability validity of diagnostic tests, and stimulate thought for conservative management of labral tears. Labral tears have been found to be present in 22 to 55% of the general population, ranging between 8 to 72 years of age. Despite an increasing prevalence, clinical diagnosis has been found to be difficult. Direct trauma from motor vehicle accidents, joint structural abnormalities of the hip, and rotational injuries in sports have all been found to increase the risk of developing labral tears. However, a study by Leopold et al. Reported that 74.1% of tears occurred in the absence of injury. More than 90% of tears were reported in the anterior and anterosuperior aspects of the labrum. Some studies have also shown a predisposition to degenerative changes after injury because of increased mechanical forces on the acetabulum. However, results are still inconclusive. The acetabular labrum is thicker posteriorly and is poorly vascularized except for its outer portion. This may be the reason for the common presentation of anterosuperior tears and its poor ability to heal effectively. The true function of the labrum is still unknown. Seldes et al. Reported an increase in the articular surface and volume of the acetabulum by 22 and 33% respectively, whilst Ferguson et al. Proposed its benefit in low distribution and joint lubrication by maintaining a constant hydrostatic pressure intra-articularly. Inter-study, Ferguson et al. Showed an increase of stress on the articular cartilage in the absence of the labrum. Because of the intricate structure of the hip joint, a variety of soft tissue injuries may be present with similar symptoms, making it difficult to accurately diagnose patients. Bradshaw et al. Conducted a study that showed a variety of injuries that may cause anterior hip and groin pain, and found the vast majority to have labral tears or FAI. Despite this high proportion, the number of patients with labral tears was not given. A systematic review by Burnett et al. Found groin pain to be the most common symptom in patients with a labral tear, with a sensitivity of 88% and 92%. Clicking was another common symptom reported by Narvani et al. With a sensitivity of 100% and a specificity of 85%, since all their patients with a confirmed labral tear on arthrogram presented with clicking. Pain is usually of insidious onset with a sharp, dull nature that increases with activity and worsens at night. Despite mechanical locking being mentioned profoundly in the literature, it was not found to be of statistical significance. Sensitivity values for objective measures have been calculated in the literature. However, due to the lack of control groups in most studies, specificity values are lacking. It has been demonstrated that impingement frequently occurs at about 80 to 90 degrees of hip flexion and is further increased by internal rotation. The flexion adduction internal rotation impingement test was found to have a sensitivity of 59% and 95% in two different studies, with a specificity of 100%. The difference in sensitivity values may be due to the different population sizes used in the studies, where Burnett et al. Included 66 tests and Trolson et al. Only included 17. The hip quadrant test, despite having a good sensitivity value, has a very low specificity, and this, along with its wide confidence intervals, renders the test not statistically significant, as a positive test may not be indicative of a labral tear. The Fitzgerald test has been proposed to have the ability to differentiate between anterior and posterior labral tears. However, this has not been linked to the results of the study achieved by the authors. It has been found to be good at ruling out a labral tear with a negative test. However, its specificity value has not yet been calculated. The Thomas test has been very poorly validated. Narvani et al. Found no significant association with the test and the presence of labral tears. They calculated its sensitivity to be only 25%. This may be due to the fact that it can generate false positive results due to the sensitivity of other structures that are put on stretch during the test. However, the authors did not give any reasons for their findings. Since the objective tests show poor reliability in detecting labral tears, studies have focused on diagnostic measures that may facilitate accurate diagnosis of labral pathology. Magnetic resonance arterography has been shown to have a higher diagnostic accuracy than MRIs by several authors. Chenzi et al. Reported a sensitivity of 90% with a specificity of 100% for MRA, in contrast to MRI, whose sensitivity was only 30%. Burnett et al. Recorded a sensitivity of 79% for MRA because it failed to diagnose 25% of their patients, where a labral tear was later confirmed on arthroscopy. MRA is usually administered alongside an injection of cortisone as an attempt to achieve pain relief before considering surgery. Fitzgerald reported that in the absence of a labral tear on MRA and an absence of pain relief with injection, this could confirm the diagnosis of snapping ellipsoid pathology. Only one study considered conservative treatment through rest and partial weight bearing with crutches for patients with labral tears. However, improvement of symptoms was only seen in 13% of the population. The majority of the studies on labral tears seek to determine which patients will benefit most from surgery. Arthroscopic interventions have been shown to have good outcomes in the long term for both pain relief and mechanical function, in the absence of degenerative changes. Despite Narvani et al. Reporting that all their patients returned to sporting activities post-arthroscopy, the results need to be interpreted carefully, as the population in this study was only 3 patients, making it difficult to generalize these results. If we had to look at the quality of the studies, it is evident that a number of flaws have reduced the statistical power of the literature. Leopold et al. In their systematic review confirmed this by showing most studies lacked construct and external validity. Most studies included small population and heterogeneous cohorts, which reduce the quality of the studies despite their positive results. Such limitations lead to an inability for statistical pooling, and the results cannot be assumed that they will work on the rest of the population. As already mentioned, most of the studies lack the inclusion of a control group, which does not allow for improvement due to chance. It also results in the reporting of inconclusive data, where in this case a lack of specificity values reduces the reliability of the objective tests despite their good sensitivity values. Wide confidence intervals were most probably due to the lack of homogeneous cohorts and inconclusive results. There are a limited number of RCTs, and most of the studies are retrospective ones, lacking the recruitment of participants in a random manner. Retrospective studies allow for bias, as the authors have an advantage of having access to the findings of clinical tests being studied and patient data. The fact that most of the studies were undertaken in a secondary care setting could indicate that the injuries were already in the chronic stages, and may not represent patients seen in a physiotherapy setting. Burnett et al. Showed his population to have already visited 3.3 therapists and noted a 21-month time frame from the onset of symptoms until diagnosis. In spite of the lack of good quality studies and limited literature on conservative treatment, we need to rely on expert opinion in order to improve our diagnostic accuracy for labral tears. Experts are emphasizing a high correlation of clinical symptoms in association with labral injury, and therefore a thorough subjective history is important. Based on the sensitivity figures from the current studies, it is fair to say that patients presenting with groin pain with and without clicking, and a sharp catching pain that increases with activity, is highly indicative of a labral tear. Currently, research has produced no objective measures to confidently rule in a labral tear, but by incorporating a cluster of tests, one might improve their specificity. Seldes et al. Found evidence of neovascularization, possibly from the surrounding synovium, that has a potential to promote healing in labral tears. We must not forget that despite there being inconclusive evidence for a predisposition of OA in labral pathology, Ferguson et al. Confirmed that in the absence of a labrum, the stress on the articular cartilage increases substantially, which may precipitate early degenerative changes. In the presence of a tear, repetitive microtrauma may prolong the inflammatory process or deepen the tear, resulting in cartilage loss. This may indicate that conservative treatment can be effected with early diagnosis. Finally, there has been some evidence that suggests that partial weight bearing and rest for 4 weeks to be effective for complete relief of symptoms, but this was only shown after infiltration with cortisone. Therefore, more prospective RCTs within a primary care setting are needed to justify this. Thank you for listening.